Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. So the patient who attended with a primarily blocked left ear, they also had some earwax in the right ear, which you'll see after we complete this left ear procedure. The earwax in the patient's left ear is what I describe as a clay type. If you've been watching my videos, you'll know that this is by no means my most favourite type of wax to remove. And that's for the reason, when you've got a clay type of earwax like this, it's quite mushy and it can quite easily block the suction probe. And you can see there, the suction probe itself, it's almost embedding itself within the wax. It's making indentations as opposed to suctioning the wax. So with this type of wax, you have no choice but to use some drops. I've just installed some olive oil earwax drops. What complicates the left ear as well is that the patient has some inflammation of the entrance of the ear canal. You can see the complexion slightly different. At the entrance, it's a bit more redder. As we go in, the complexion's a bit more paler, pink in colour. So we call that otitis externa. Otitis externa can manifest itself in many different ways, and that's because otitis externa is an umbrella term given to a collection of ear infections and or inflammation of the outer ear canal and the outer membrane of the eardrum. And I've used some olive oil spray, and I find olive oil spray helps to bind the wax together. Again, if you've been watching my videos, I like to make comparisons to food, and I always describe olive oil spray which has a similar effect to an egg in a potato cake or fish cake recipe. When you want to bind the ingredients together, and you can see what's happened there. This wax is now suctioning. It's no longer blocking the suction probe, and it's coming out in large chunks. Still a lot of wax in there, you can see it, but it's coming out a lot easier now. You can see the entrance there, it's a lot more a darker pink, and as we proceed into the ear, the colour's a bit more natural, it's a bit lighter in colour. So the patient does chronically suffer from otitis externa. They use some spray prescribed by the doctor. Now this residual wax is right on the eardrum. So what I'm doing at the moment, some oil is still there, and when you suction, sometimes when you've got oil in, the camera can get a bit blurry. So I'm just suctioning the oil out first, and once I've suctioned it all out, the blurriness should go, and it's then safe for me to proceed further in the ear. So this is really impacted against the eardrum. Now you'll see in a moment the patient's got a prominent anterior recess. So near the eardrum, there's a natural narrowing of the ear canal. We call it an isthmus, and then the ear canal widens again. And that creates a couple of recesses, one inferiorly, so it's almost like a trench at the base of the eardrum, and one, in the case of the left ear, on the left-hand side of the ear canal wall, is like almost a hidden cave. And in the case of the right side, there'll be a hidden cave in the right-hand side of the ear canal, adjacent to the eardrum. And we call that the anterior recess. And it can be quite difficult to access with some visualization methods, an otoscope, for example, or even a microscope. You may not even see the contents of the anterior recess, but with an endoscope, more often than not, you can, and that's because an endoscope offers you a much wider panoramic field of view, and that's why it's used in keyhole surgery. Not only is it minimally invasive, so it's just a keyhole incision, you can put an endoscope in, a small rod lens of different diameters, but small diameters, so it doesn't leave any massive scars. But it's the view an endoscope provides, it's unparalleled. So you can see, you can almost appreciate the patient's curvature there of the ear canal. So you can see the bends and twists, and you can see that prominent anterior recess, and you can see on the left-hand side that wax and dead skin. I would say it's more dead skin actually, it's quite crusted, and it's lodged in the anterior recess. If you wondered what an anterior recess is in the ear, there we are now, that's where the wax is. Now what's interesting is once we've removed this, and I will remove it, there's some hard and thick and dead skin on the eardrum. Almost looks like a verruca. And you can see just removing this. And we did get the patient back a week later just to make sure it all settled down, and it had settled down, so there's nothing to worry about. As you can see there, we probably on this anterior superior portion of the eardrum, so top left, you can see there's some hardened skin there. So I'm just trying to peel some dead skin off the canal wall there, which is really delicate because it is a sensitive part of the ear. You can just see there, there's some thick and dead skin in the middle. It's mild, I would say it's more of a blister. It's not actively bleeding. You can see this dead skin is a lot more crustier. It's harder. It's got a rough surface. So the patient's symptoms are relieved here. As you can see, they've got a really, really narrow part of the medial canal wall. So as we go in, it's almost elements of exotosis, otherwise known as surface ear. If you're exposed to cold air or cold winds, the bony part of the ear canal, the bone there, the blood vessels dilate when it gets cold. And the blood vessels, when they dilate, they help promote growth of bony spurs. And there's typically 3 in the case of surface ear. You get one at the top of the ear canal around 12 o'clock, then one at, say, around 3 o'clock or 4 o'clock, and then the other around 9 o'clock. And there's 3 prominent brems. The technical is periosteum refrigeration. That's what they call it. So the bone, the periosteum bone, it refrigerates because of the cold temperature. There's cold water or cold winds. Causes the blood vessels in the bone to dilate. The dilation of the blood vessels helps promote growth of bony spurs, and in some cases the medial part of the ear canal can completely be constricted with these 3 bony spurs. And it's possible that this patient may have very mild surface ear, because you do get, especially on the left, there's quite a prominent bulge there, but nonetheless, it's not going to affect the patient's hearing. In the extreme case of surface ear, it can. You can just see some dead keratin just on there still. I just want to remove this gently. So just using a fine end gauge. The rest of the eardrum's fine. I'm happy with that. So we did get the patient back in, and that would all heal, so that thickened skin, because it was compression, there was a lot of wax there, and the dead skin that was on the surface of the eardrum was really rough, and it just abrased the surface of the eardrum, and the skin had thickened there. So this is the patient's right ear. It's not as bad. The consistency, so this is a bit drier. It's not as clayey, if that's a word. That I managed to get out in a big piece. It's just another piece of this drier wax and dead skin, a bit more medially. Well, the patient's ear canal is narrow, but it's not as narrow as the patient's left one. You can see that it's not as much inflammation there at the entrance, or if there is no inflammation there. Lovely healthy eardrum. Again, the patient's got a bendy, twisty ear. And again, you can just see elements of possible surface ear. So on the left-hand side of the ear canal, a bit deep, you got a slight bulge there. The patient did confirm that they, in the younger days at least, where they did used to go cold water swimming quite a lot. I do have a couple of cases of surface ear. If you look through the video, you can see how extreme they can be, these bony protrusions. So some dead keratin on the surface of we call this the anterior, so it's the front part of the ear canal, and lateral, so near the entrance of the anterior lateral canal wall. Just using a phone just to mop that up. So when we're on the cartilaginous portion, which is the outer third, we can put a bit of pressure on the canal wall, but on the inner 2/3 of the ear canal, we wouldn't be able to do this. It will just be too uncomfortable for the patient. Just see how bendy the ear canal is there. So the ear canal bends to the left and then back to the right. So there's quite a really bendy ear. Some dead skin on the... So this is the posterior lateral canal wall. So posterior is the back part of the ear canal, and lateral once again is near the entrance. This is some dead keratin there and just gently peeling off. You can just see how bendy the ear canal is. It veers off to the right of the eardrum. It's like an S shape. I'm not going to get all of it out. I've tried to. It can be a bit uncomfortable for the patients. But the occlusion's all been removed. We'll have a nice shot of the eardrum hopefully in a moment. As I tell you, there's a slight bit of inflammation there, but not as bad as the left. There's the patient's eardrum, nice now.